Okay, let us begin. First of all, I would like to welcome all of our guests. Thank you for joining us this evening at another PUA webinar. We'd like to welcome our special panelists who are with us this evening, Dr. Sahar Wertheimer, who is a reproductive endocrinologist, a fertility specialist at HRC here in Los Angeles, and Bracha Rich, who is a genetic counselor for the amazing organization J-Screen. For those of you who are not familiar with J-Screen, we'll actually give the mic over to Bracha. You can tell us a little bit about what you do at J-Screen, and then we'll head over back to Dr. Wertheimer talking a little bit about egg freezing, and we'll get tonight's webinar on, we'll get the ball rolling. So Bracha, why don't you introduce yourself and tell us a little bit about what you do as a genetic counselor and what you do in the organization J-Screen, what it does for the community.
Absolutely. So I'm a board certified genetic counselor. Genetic counselors, we do a lot of different things, but my specialty has always been reproductive medicine. So helping people who are pregnant or people who are trying to get pregnant, whether that's now or in the future, really have healthy families. And I work for an organization called J-Screen. J-Screen is a national nonprofit in the United States. Our mission is to get people tested in a way that's easy, affordable, and really high quality. And we do two different types of tests, which we'll get into tonight a little bit. We both do carrier screening for diseases that are common in the Jewish community and general community. And we also do cancer screening for 48 genes that are related to hereditary cancer. And again, we'll talk about that a little tonight, but it's an incredible organization. And if you have more questions after the webinar, feel free to reach out to us. Our website is jscreen.org. You can definitely look it up and get more information there.
Beautiful. We'll put that contact information in the chat box at the end of tonight's session. And any of the participants, the attendees, feel free to write questions to us using the chat box, and we'll be able to respond hopefully in a timely manner. So let us begin to discuss what the topic of tonight's event really is, and that is preserving our future, the beauty, the science, the medicine, and the halacha behind egg freezing. Egg freezing is an amazing technology, an amazing opportunity where people who are, for whatever reason, who are unable to have children right now are able to be proactive, to freeze their eggs, and to then use those eggs hopefully in the future when the time is right. Dr. Wertheimer, as a fertility specialist, can you just tell us a little bit about, first of all, before we get into anything, I think what's so important to kind of address first is how common is egg freezing? As a physician, as a woman in the community, tell us a little bit about egg freezing, how common it is. Who do you see? What type of patients do you see? Who is inquiring? Who is considering egg freezing? And then we'll talk a little bit about what is egg freezing? What does it entail? What does it look like? What does the process look like? What does it cost? We'll talk about all of those very important items, because there's so many people in our community who could really, really benefit from this information.
Yeah, so hi everybody. Thanks for coming. And I wanted to point out in answering your question that I see a lot of what looks to me like males on the chat as well. And I think that that's really great, because part of this conversation when it comes to egg freezing in the Jewish community, a lot of it has to do with shidduchim, and we get a lot of people who are concerned. I've even had males sometimes come in. I've offered this before and I'll offer it here too. If there is a male who's in a relationship with a female or dating someone and is concerned about her age, I'd like to offer a little bit of reassurance, because I think what's out there might be a little bit worse than what people really think. Or if she has frozen eggs, I'm happy to do a free consult to answer some questions, because it's just so important that everyone has the actual facts and not just, and I have spoken to men that have been in relationships with females and have been worried about their age, and then when after talking they realize that actually there's a lot more potential than they think. So egg freezing in that respect. We see so many women doing egg freezing, Jewish community, not Jewish community. I see women ranging from their 20s to their 40s. And sometimes people ask me, is it too late to come, in their later 30s or 40s? And I would say absolutely not. It's just a conversation about what is your expectations and how can, I'd like to adjust expectations of what you can really see statistically coming out of these eggs. How many rounds you might actually need to do does increase as your age advances. And but that being said, we absolutely have normal embryos resulting from even eggs frozen in their 40s and subsequent children.
So let's take a step back. Pretend, and the truth is, there are so many people, men and women, who are just unfamiliar with biology. We're unfamiliar with the biological clock. We're unfamiliar with what our body does. How do we have eggs? How do those eggs express themselves on a monthly basis? When I harvest my eggs, does that mean I'm actually tapping into my reserve and I'm putting myself at a disadvantage? Can you give us a really, really basic bio lesson? How does the body work? How does the female body work? And why is egg freezing an amazing opportunity for women? And what age bracket are we talking?
Absolutely. So, women actually are born with all their eggs as opposed to men who continuously make new gametes throughout their lifetime. We actually have maximum amount of eggs when we are in utero, about 20 weeks. So we have 6 to 7 million eggs in our little ovaries. By the time we're born, we'll have in the some quick math, right? You're not. Can you guys still hear me?
It was hard.
You cut out a little bit for us,
Cut
Dr.
out a little bit. When you're born, how many eggs do you have when you're born?
Okay. Okay, so by the time you're born, 1 to 2 million eggs. So, and then, like I said, in menopause, you're into the thousands. So if you do some math, you're not losing one egg every month. I think that's a misconception. People think they're losing one egg with every period every month. In reality, what's happening is that from that background bank of eggs in the back of your ovary, a group moves forward to the front of the ovary every month. They're all competing to be the egg that you are going to ovulate that month. Whether or not you get pregnant with that egg, the rest of the group that was competing doesn't get saved for a future cycle. They get resorbed by your body. And so essentially in technology like egg freezing or IVF, what we're doing is trying to get you to grow all the eggs you would otherwise have lost that month and save them for the future. So we are not tapping into your reserve and making you go through menopause sooner. We are rescuing what you were otherwise going to lose.
Such an important piece of information that many people are not aware of.
Yes,
So,
absolutely.
At what age do you tell a woman to begin considering freezing her eggs?
I would say that by and large, I tell women in their young, or I tell Jewish women who want larger size families in their younger 30s to come freeze their eggs. And the reason is because for everybody, it's a personal cost benefit analysis of the younger you are, the less likely you are to have to use these eggs, and the more likely you spent money that you may not get back. But the later you are, the less likely the eggs will turn into the amount of children that you want, and but the more likely you will need to use them. So you'll need to end up doing more cycles the older you are to achieve the same amount of normal embryos as you would have with lesser cycles when you're young. So it's very important to take into account your ideal family size. So for our Jewish women or Orthodox Jewish women who may want 3 to 4 at minimum children, I would recommend coming in your younger 30s, even your older 20s, depending on the overall picture. It's never wrong to come in your late 20s and just do a check-in. Let's check your ovarian reserve with some of the markers that we have and see, are you average, are you above average, or are you surprisingly very low? Because if you are one of those people that has a surprising surprisingly low reserve, you would be better off by doing it in your 20s. And that being said, if there's any reason to suspect that you may have issues with fertility, like you've already been told that, sorry, you have endometriosis, or you know that you have the Fragile X mutation, which I think Bracha will speak about a little bit more, or something like, or you know that you have a genetic mutation or BRCA, for example, that you're going to want to do IVF anyways, better to come when you're younger.
Yeah, and last question before we turn the mic to Bracha. I think it's important if you can tell us, we don't have a graph with us, but if you could graph out like what a female's fertility looks like in her 20s, in her 30s, her low to mid 30s, mid to high 30s, and then 40s, kind of just give us a good picture of what happens to female fertility as those years go on and they hit 40s and 41 to 44, 45, and then plus.
Absolutely. So actually, if you give the mic to Bracha for just a second, I will show you a graphic that will make it very pretty. Give me 1 second. So basically, like I said, you start with all your eggs when you're born, and you lose both quantity and quality as you get older. So around age 35 to 37 is when you have the biggest drop off in your quality and quantity of eggs. And for everybody, that is a little bit different, but essentially, depending on which study you read, you're going to start to see a rate of loss that's faster. A lot of times, people get very scared by the statistic and they think that they jump off a cliff when they're 35 and they're no longer fertile and it's not worth it to come get their eggs frozen. It's not that you jump off a cliff, it's just that the rate of loss becomes a little bit faster. And so it's incredibly important to come earlier, that you just get more bang for your buck.
Nice. I think it's an important graph. It's important to see it.
It's just that simple. What I would, can you hear me?
Now we can.
Okay. I would say the majority of women by they're 35, 50% of their eggs are going to be the time they're 40, down to 25%, 75%. Should I move? Okay. So that is essentially what I wanted to just point out to you. I would say that for me, the biggest drop off is after 40, and then after 43 is the next big drop off. So we see, like, it's like when I'm counseling a patient that's 41, 42, 43, it's a different conversation for each of those patients. The younger you are in your 30s, the better, but absolutely it's not too late, mid to late 30s. And why don't we give the mic to Bracha? I am going to try and find a better spot to sit in.
Okay. Or we could just tell the wind to stop blowing somewhere.
Yeah, the Palisades, they're coming over here.
Okay, Bracha, tell us a little bit about your experience with egg freezing. What types of patients are you counseling? How does your position as a genetic counselor at JScreen kind of fit into this whole story and really help service the community in a very special way?
So I think it's really important that everything that Sahar and Dr. Wertheimer and Rabbi Siegelman are talking, there's a lot of different pieces that go into a egg freezing or IVF journey, and genetics should definitely be a part of that. So we have certain genetic conditions where we know that we have the genetic condition. We can tell that we're what we call affected in genetics. We have other conditions where we may be called something called a carrier. So just a little genetics background. We're all born typically with 2 copies of every gene or instruction, one from mom, one from dad. And what can happen is because we have 2 copies, if one of them isn't working, the other one basically picks up the work. Think about like we have 2 kidneys. We really only need one functioning kidney typically for our body to have all that it needs. And what can happen is that people can oftentimes look healthy, seem healthy, but being a carrier may impact their fertility. And something that Dr. Wertheimer mentioned, which is hugely important, is something like being a Fragile X premutation carrier. So Fragile X syndrome is a condition that would affect someone. They would know that they had that condition, and they would know probably pretty early on as children. But somebody who's a woman that's a carrier would seem totally healthy, would be living, her regular life. But part of being a carrier for this particular condition means that you would be at higher chance or higher risk for something called primary ovarian insufficiency. So your ovaries, which are what make our eggs, they may stop working a little bit earlier than somebody who has not being a carrier, someone of typical health. And so knowing that status earlier by doing something like carrier screening would bring you to Dr. Wertheimer's office earlier, which would mean that you'd have better success with egg freezing, with IVF, and ultimately with building your ideal family. And so I think that using that as a tool is really, really helpful. There's other genetic conditions where sometimes the symptoms are so variable from person to person. So there's an example of a condition that's actually more common in the Jewish community called congenital adrenal hyperplasia, or CAH for short. And a lot of the times people don't realize they have this conditions. They have the two non-working copies, but it can mimic a lot of other very common conditions in a more mild state. For example, some women will have irregular periods and will have a little more hair growth. Well, their doctor may say, hey, you have something called PCOS, super common, not to worry. But again, that situation would definitely warrant a visit to Dr. Wertheimer's office, would definitely need help from someone like Rabbi Siegelman and Dr. Wertheimer in planning cycles and trying to get pregnant eventually and egg freezing. So I think it's really important when we talk about carrier screening. Sometimes we don't think about that it can impact our fertility, and that can, and again, impact our plans, right? If we know we want to have a bigger family, if we had a little bit of insight into what our future looked like, we might go see Dr. Wertheimer earlier. Maybe if I would see her in my later 20s or mid 20s, if I was still, not in a relationship where I was having kids yet. And I think that's really helpful. I think another thing that's really helpful is if someone knows that they're a carrier for something. Fragile X is a little tricky because it's on the X chromosome. That's the sex chromosome. So women typically have two X chromosomes, men have an X and Y. Being a carrier for an X-linked condition would mean her male children would be at higher risk depending on the situation of developing the actual condition. So again, that might lead you to Dr. Wertheimer's office anyways, because you would want to screen embryos later when you did have a partner to make sure that those embryos that you were putting in were not at high risk for that condition. So there's a lot of kind of different pieces to carrier screening that are so important, and knowing your results can really impact not only having healthy children, but like making sure that you have children on a timeline that feels comfortable to you.
Yeah, the truth is you're not making this stuff up. Literally today, I spoke to a woman who was inquiring about her daughter. Her daughter is a carrier of Fragile X. She has a son who's affected, and the daughter is not yet starting shidduchim, but she's about to start shidduchim. And she wanted to discuss what does that look like. What is her future going to look like, whether it's in regards to her ovarian reserve or just egg freezing in general. Should she be doing egg freezing at a younger age, or IVF when she gets older, so she shouldn't spread the gene. Let's take a step back. And throw the ball back into Dr. Wertheimer's new court. Welcome to your new court, your new location. You look great. Now, here's the question: what does the process look like? If I'm a woman, I'm 34 years old. I go to my OBGYN. I have an annual checkup, a pap smear, whatever. I go through my whole, and the doctor says, you really should consider egg freezing. Go call Dr. Wertheimer and go make an appointment to discuss egg freezing. So now, great, we had our consultation, you and I. You told me that you agree with the OBGYN. Like, now what? I'm going to get my period, and then walk us through that process of what it looks like for a patient who is leaving the doctor's consultation, and the next time they come back, they're already freezing their eggs. What does that look like?
Yeah. So at initial consultation, we do your ovarian reserve labs and just kind of give you some expectations of how many eggs we expect to get if we were to do a retrieval on you specifically, and how many rounds we may want to do to get your family goal. That being said, you ultimately don't know until you try and you go through it. So the next steps are we give you, depends on your clinic and your protocol. My personal preference is to do something called luteal priming, where I find you in the third week of your cycle, give you some medication, and then give you a calendar. So you'll take the birth control pills for the majority of women, not everyone, but the majority of women. You'll come back at a certain date. We'll make sure everything looks good to start. And then we start you on injections. So it's 2 injections every night for 10 to 14 days. During that time period, you're coming into the office every other morning, essentially, for a transvaginal ultrasound and blood work. And we're calling you in the afternoon and telling you, hey, go up on your meds, your follicles are growing a little slow, or go down on your meds, your follicles are growing a little fast.
Should I be alarmed if you tell me that my follicles are growing slow? Should I be alarmed, or is that normal?
Absolutely not. We'll get you there. It's
Okay.
very much titrated to everybody, to your body. Nobody's a textbook. Some women, especially women with PCOS or women with very abundant reserves, actually some or who have been on birth control pills for a very long time, they might go a little bit slower, and some people go a little bit faster. But we will titrate the medication to your body's response. And then at a certain point, we may add in a third medication to prevent you from ovulating. And then as we're getting close to the end of that 10 to 14 day period, we're going to tell you, okay, this is when we're anticipating your egg retrieval is going to be. We tell you when to do something called a trigger injection, which causes you to ovulate and release those eggs from the wall of their follicle, which is the fluid-filled egg sac that they're in, into the fluid of the follicle. And then before your body can let those eggs kind of travel through the uterus, we arrange an egg retrieval with you in our operating room. Usually that's 35 to 36 hours after your trigger injection. So that part is timed very precisely. And then you meet us in the operating room. You will be under anesthesia. You won't feel it. You won't remember it. We're going to go in with a transvaginal probe attached to a needle. We poke through the vaginal wall. We poke into the follicle, aspirate out all the fluid, and with it comes the microscopic eggs. So when you wake up, we'll give you a rough count of how many eggs we got. And then after the lab strips the eggs of the cells surrounding them, they can tell if those eggs are what's called mature, meaning capable of being fertilized by sperm. And we will then freeze those eggs until you're ready to use them.
Amazing. I have a few questions for you.
Can you
Um,
tell I've been asked that question before?
I just thought you prepared for the webinar so diligently. Um, I will ask you a question that I get almost on the daily.
Hmm.
You mentioned 10 to 14 days of injections.
Hmm.
Okay. So inevitably, you're going to have either one or two Shabbosim, Friday night or a Shabbos, during that window of time.
Hmm.
Now, suppose I'm just gonna take the liberty and tell people that generally, I presume you tell people to take the shot at the same time every night.
I say within a few hours. The one that's very strict is the antagonist.
Yeah.
The third injection, which prevents you from ovulating. And that can always be taken earlier, not later. So if
Right.
you had a very strict rabbi, not Rabbi Siegelman, he'll let you do anything you want. Um, I'm totally kidding.
Yeah.
But if you had somebody who was like really not wanting you to take injections on Shabbos, I would say, you could take your antagonist at the normal time Thursday night, and then Friday night you can move it up, and then Shabbos day, I guess you're kind of going to be stuck if you need to take it on Shabbos.
The antagonist. But what about the other injections? Like suppose your time is 5 o'clock, right? So depending on the calendar, so 5 o'clock could either be before Shabbos, right, or it could be after Shabbos. So let's say it's you 5 o'clock. You want to take it a little bit earlier, right, to make it
Yeah,
before
before
Shabbos. But
Shabbos,
then
and then take it
but
a
then
little.
tomorrow on
Yeah.
Shabbos, 5 o'clock is still going to be Shabbos. So is it okay if I do it an hour early on Friday and then push it off another hour on Shabbos? So
Yes,
it'll be after Shabbos. I can make Havdalah and then do the injections.
absolutely. Yeah. I usually tell patients within a few hour time frame, so it doesn't need to be exact.
Okay, that's a very important medical piece of information which dictates how we paskin halacha. Because if the doctor says no, it needs to be done at this time, then we'd have to do the injections on Shabbos. But if the doctor is saying
Right.
that it doesn't need to, so then let's try to do it before Shabbos and then after Shabbos.
Right.
Okay, I have two other questions. By the way, I just want to tell everyone that the questions are coming into the chat box. They're flooding the chat box, which is great.
Yeah.
They're flooding the chat box quicker than I can ask the panelists. So I want to tell everyone that to keep on asking questions, and hopefully we'll get to them at the end. Sometimes I'm able to weave them in immediately, but not always. Now, these injections, so there's 2 injections a day, correct?
2 injections a day until we add the third.
Okay.
I'm going to speak to the protocol we mostly use.
Okay, someone asked why. Maybe this is a longer question, but why are there different protocols? Why isn't it just like, you know, do this and then you'll have your eggs at the end? Why are there different protocols, and why if you go to this center they may do one way, and if you go to a different fertility center they do what is it? Isn't it the same hormone? Isn't it the same dosage? Can you like?
It is, and I would say that if you looked at the core of most of the protocols, the principle is going to be the same. There are protocols where you add in an antagonist to prevent you from ovulating. There's protocols where you start with an injection which prevents you. Some of them are more old school, some of them are newer. Ultimately, the reason why there's different protocols and not one agreed upon protocols because we really don't have data that shows the superiority of one over the other. A lot of them have evolved over time due to a lot of other factors like scheduling and ease of use and non-inferiority. So we're seeing like with certain ones, like the antagonist actually does the same or better than the older Lupron protocols. It could also be just what your doctor or your clinic does the most and is the most comfortable with. Very rarely will a different protocol be a huge difference maker for somebody.
Nice. Okay, just last question, and then I want to ask something to Bracha. But this was a great question, and thank you for asking it. You mentioned that throughout the process, that 10 to 14 days, so there's monitoring almost every other day.
Yeah.
Is that something which is going to prevent me from being a functional working woman because I have to go to the doctor all the time? And then furthermore, on the day of the retrieval, when they're actually extracting the eggs, am I taking off 1 day of work? Am I taking off 2 days of work? Am I not taking off any days? Like, tell us a little bit about how the whole egg freezing process fits into my normal life as a woman, as a professional, and who want to balance both.
So I would say for the most part, clinics are set up to accommodate working women. And so we have you come in to do your ultrasound labs in the morning. And then you're on your way to work. They result later in the afternoon. We'll call you or email you or whatever it is with your further instructions. That being said, I sometimes think that patients have a little bit of an unrealistic expectation with how much this needs to jive with their lives. You are going through a medical procedure and a medical protocol, and it's okay to tell your boss, you know, I'm going through something right now without specifying, and I need a little bit of wiggle room to come in, you know, 15 minutes later or whatever it is, or to go take a phone call. It doesn't have to be like, you don't have to tell your boss what you're doing to get a little bit of an accommodation. You'd be surprised, and we're happy to write letters to help you out and such. But I would say for the most part, we're set up. We know people want to go to work. We try to get you in and out, blood, transvaginal ultrasound, you leave. We call you later with your results and instructions.
So
The day of the
we're talking about 6 o'clock in the morning, 7 o'clock in the morning. Like, what time are people coming for their
depends which clinic. Like my clinic is a little bit does not run at 6 in the morning. It's more like 7 to 9, 10, 11. And I think that's very largely a West Coast thing.
Yeah. In New
East
York,
Coast, like especially New York
I'm
City, I
telling
think they
you,
might have to.
in Manhattan, 7 o'clock in the morning, the waiting room is packed.
Yeah.
Packed. 7 o'clock in the morning.
Yeah, I think it just depends on a geographical location and how, like, you know, what else is available. But certainly if we have women that are like, we need to be at work at this time, we always try to support our working women because we are that too. And then the day of the retrieval, we have you take off because the anesthesia will make you groggy and not a good decision maker. And then whether or not you need to take off past just the day of your retrieval. Depends on how robust of a response you had. So my patients with like severe PCOS, I do tell them to try and expect or try as much as possible to be lying low. So if they're another physician like me, for example, I'll tell them to go see clinic patients, but not necessarily to stand in surgery. So it's adjustable and we can discuss expectations as we see how you're responding.
Amazing. Okay. There are more questions that are coming in, but there was an interesting question that caught my eye. Let me try to find it. And it was about the BRCA gene.
Yeah.
And we wouldn't have anyone else talk about this, on any other
Yeah,
webinar other
she
than
wrote, what
Brother
about
Rich. I can't find it right now,
timing with
but
BRCA mutation, wanting to have kids early?
yeah, so that I thought that was such a great question that was submitted, and again, we're lucky to have Bracha Rich here with us to discuss it. But we know that the BRCA gene, the BRCA gene, is very prevalent in our community, in our circles. We know that unfortunately, a woman without knowing anything other than family members passing away, either getting it, having breast or ovarian cancer, and just aware that it's in the family, a mother, a grandmother, an aunt, all of the above. Tell us a little bit about a woman. Let's take a 32-year-old woman, not yet married, a mother, a grandmother, and an aunt were all diagnosed with breast cancer or whatever it may be. What type of advice do you give this woman? Should she be testing? Should she not be testing? Should be looking into egg freezing? Should she not be looking into egg freezing? Give us a little bit of background and how you would counsel such a patient.
So I would say there's a lot of different pieces to that. I'm going to unpack them slowly. There are people in our community that know that they are carriers because, again, there was a parent that tested, they tested. And if someone's a known BRCA1 or 2,
thank you for saying parent. I was saying mother, grandmother, and aunt. The BRCA gene is in men as well. So thank you for correcting me.
It can always come from mom or dad. And that's why we're very, in genetics, we don't just want to hear about mom's family history. We want to hear about dad's as well. Sometimes we don't, but it can come from mom or dad.
Yeah.
What I'll say is if someone is a known carrier, they know they carry a BRCA1 or 2 mutation. As a woman, that puts you at an increased risk for breast cancer. Breast cancer is a little different because we know we have really good screening to prevent someone from getting cancer. So things like mammograms or breast MRIs or even ultrasounds, and we can combine that with clinical. We have really good proven methods to detect breast cancer early and screen people. Ovarian cancer is a little different. Ovarian cancer is one of those things that when it's caught often very, very late stage, not super treatable, and people don't typically survive with that. So we know someone who is carrying a BRCA1 or 2 mutation. Ovarian is it's considered to be a rare cancer in like contrast to breast cancer. We know that we want to do everything we can to prevent them from getting ovarian cancer. And our limitations with screening is we don't have good screening for it. So typically someone who knows that they're at an increased risk for ovarian cancer is going to remove their ovaries and fallopian tubes really at an early stage in their 40s. What becomes tricky, Rabbi Siegelman, is what you're mentioning. I'm in my 30s. I haven't met the person that I want to have kids with yet. I desperately want to have children. Or, I have met that person, but we haven't had kids yet. Should I freeze my eggs? Should I do IVF? And I would absolutely recommend having a consultation with someone like Dr. Wertheimer and Rabbi Siegelman, because there's kind of two pieces to that. Yes, we want you to be finished having your children a little earlier than someone who doesn't have this ovarian cancer risk, really to save your life. But also you may want to do IVF and do that process for another reason, because you may want to do something called PGT or pre-implantation genetic testing. And they do that with IVF. And that's a way for us to screen the embryos, to screen those, early embryos before we even put them back into a woman's body, before a pregnancy is established, to check for that BRCA1 or 2 mutation and make sure we're only putting in embryos, if we have them, that don't have that mutation. And so you can really stop that process with you, and you can make sure that your children are at lower risk. I know Dr. Wertheimer can talk about this a little bit. Sometimes we're in a situation where all our healthy embryos still have BRCA1 or 2 mutation that we didn't want. And then that might be a conversation of we put in male embryos because the risks are a little bit different for male embryos than female embryos. And that's a great conversation halachically to have with someone like Rabbi Siegelman as well. And I think there's all those kind of pieces to that. I will say also, we call people who are carriers for a mutation, we call them previvors. They're not survivors, they haven't had cancer, but they're previvors. And they may just want to do egg freezing off the bat. We also have people who unfortunately find out that they are diagnosed with cancer, and Dr. Wertheimer can talk more about that. Their process is a little more rushed. They may have to do egg freezing. And this is an amazing way to preserve their fertility so that they can have children when they're ready for having kids.
Very, very, very important. Thank you very much for that. So let me read
Um,
this. Yeah.
I just wanted to add that for the BRCA mutation, there are some studies that actually show decreased ovarian reserve in those patients. So that's yet another reason to come see the fertility specialist earlier.
Okay, this is a question for both of you. If a woman has not done genetic testing before egg freezing, single woman, has never done any testing whatsoever, if she's planning on doing egg freezing, do you recommend genetic testing first, where the eggs frozen will be genetically tested themselves, and you can kind of avoid that whole process before they went ahead, and you could just test the actual the DNA of the actual embryos?
I'll let Sahar talk about the actual testing piece, but I would recommend everyone, if you are going to a fertility clinic, I would recommend you get genetic testing earlier because it can inform decisions. So we talked about CAH, right? Someone who may have that genetic condition, they didn't even know, they're not even a carrier. They may want to do IVF now off the bat because they now know they want to screen for a condition like we talked about with Dr. Wertheimer, even though they weren't thinking about that before. So I would always recommend it's earlier, again, and it'll inform your path on how you're going to have kids. So I would always recommend doing testing, even if you froze your eggs, right? You're coming back to Dr. Wertheimer, you've met the person that you're going to have kids with. I would recommend, again, testing your genetics because that may impact, if you guys choose to try and conceive naturally, or you
Exactly.
go straight back to Dr. Wertheimer because you find something else out. The idea is it gives you more options and more choices. And Rabbi Siegel and I have talked about a lot of situations in pregnancy together. It's much easier to talk about this with Dr. Wertheimer than talking about this when someone's actually pregnant. It's a very different conversation halachically and emotionally.
This is interesting for me to hear because I would have disagreed. I would have said that I do not do genetic. I don't encourage genetic testing when somebody is coming to do an egg freeze. But I'm curious to hear. So the way I understand it, the genetic testing is really looking for autosomal recessive diseases where your partner needs to also carry that genetic mutation in order for it to affect your future decision making. So because the panels are continuously being updated and updated, I tell my patients, let's wait until we find our partner and we're making embryos to do it, or else they have to pay for it multiple times, or they think they've done the testing and then their partner does the more expanded testing a few years later, finds something as a carrier for it, and then they mistakenly think they don't have it. So I prefer to have them do it at the same time. Do you disagree with that, Batya? You think there's things like CAH that may change things if the partner doesn't
I
carry
think
it?
Fragile X is a big one for me because I see so many people who come through with it. It's much more common than we think.
Yeah.
And for me, like that would inform, I'm talking for me as a person
Yeah.
and disclose on this webinar. I've done IVF and I
Uh-huh.
the Heart and Rabbi Siegelman, both, as professionals, as an amazing resources for our community. I think we all think we have unlimited time as human beings. We really do. We think like, okay, I'll deal with it later. But if it would be the decision factor for you to get moving a little faster and you want that bigger family, testing for Fragile X specifically, which can inform whether you're going to potentially have primary ovarian insufficiency, I would definitely recommend that. I do agree for everyone, and we've talked about this before. Everyone should be getting their panels updated every 3 to 5 years, even if you are having children. I've updated it between my kids because, my first child is much older than my younger child, and things do change. And again, that's going to inform your risk. I do agree, and I will say this to every single person here. Please, please, please have a medical professional look at your carrier screening reports with whoever you're having a baby with at the same time, because that can lead to error. Like I've seen situations where a husband was tested for 10 things and the wife was tested for 300. And he's like, I'm not a carrier, we're good. And I'm like, well, actually, you weren't tested for what your husband is a carrier for. So the testing isn't. I just, again, every person is different, but I think information earlier, especially if it's going to impact fertility, with things like X-linked conditions, yes, testing embryos, obviously, when you're egg freezing, you're not testing embryos. And I think you can definitely talk about how that's a little different.
Yeah.
But I would definitely recommend if your panel's been done over, 2 years before you are at the stage of making embryos, update your panel, because it'll
Yeah.
impact if you want to do something like we talked about, like PGT.
Okay. I want to just say one thing. If you guys place your questions in the Q&A box, they'll remain anonymous. So if anybody's not asking questions because they don't want their name to appear in the chat, if you put it in the Q&A box, your name will
Oh,
not come up for
the
everyone
chat
else
is
to
also
see.
anonymous. The chat is completely
Oh, is
anonymous.
it?
Yeah, the only people that see the chat are you and I are the
Oh, you're
hosts.
right. It's directed directly to the host panels. My
So
bad.
the chat is
Perfect.
also
Okay.
an anonymous way of submitting. Yeah, it's
Okay.
all anonymous. You have nothing to worry about.
Good to clarify. Everybody can freely put in their questions.
Right.
Also, Brock, I
Now you
see
can
it.
tell us what you really think.
Yeah.
Um,
Brock, I see a great question for you while you're on that topic.
Sure.
That is karyotype the same test as genetic testing prior to the process?
So no, we have a lot of different types of genetic tests, and that's why I always tell people, like people will come to me and say, "Oh, I did genetic testing before I had kids. I know I don't have the BRCA gene." And I was like, "You did carrier screening. That's a different test." So really, carrier screening is one type of test. A karyotype is a test where we zoom out and look at everyone's chromosomes. Chromosomes are, obviously, when you have the best analogy behind you, they're big bookshelves of our DNA. It's how they're organized, and that can be really
okay, sitting
helpful
here.
who for people who may have their chromosomes, they have all the right genetic material, but they're organized a little differently, which may have, cause issues with getting pregnant later on. It may also reveal to us that you have a large chunk extra or a large chunk missing. Um, and so that may be helpful. Typically, as a genetic counselor, we don't recommend karyotypes off the bat for someone who's just doing egg freezing unless there's a family history. So if somebody came to me, and they had been pregnant multiple times and had multiple miscarriages, we might recommend a karyotype. If a male had come to me and had male infertility, so he was making low amounts of sperm or didn't have any sperm, we definitely recommend a karyotype. But that again, then Sahar, you can chime in if that's in standard in your practice. We don't typically recommend karyotypes without an indication, just for egg freezing. Not that it's a just, but that's just not typically an indication we deal with.
No, I agree. I also only do it in somebody who I have a reason to test for. Um, Back to the question about whether you can test eggs versus embryos. You cannot genetically test eggs. You cannot genetically test sperm. And the reason is because they each carry half of the genetic material that we need to make a full embryo that has 46 chromosomes, like most of us. So I need the full complement of chromosomes in order to test the gamete. So only embryos can be tested.
Let's do one more practical question about genetics, and then we'll go back to egg freezing. The last question that was just asked is, where can I get these genetic tests performed?
That is a really great question. If you are someone who has a gynecologist, they can typically do all this. Sometimes they don't feel comfortable. I'm just being very honest. Sometimes
Say
they
the
feel
patient or the gynecologist?
the gynecologist may not feel comfortable and sending these type of tests. So I've had a lot of patients who I've worked with, and they just say like, I've never ordered a karyotype. I don't know how to do that. Someone like Dr. Wertheimer feels very confident in ordering these type of tests. So you can, even if you're not freezing your eggs yet, but you want to get that really good workup before to learn, you can definitely do that. If you're interested in ordering carrier screening without a doctor, you don't have a PCP yet, or you just don't have one, you can actually do it through JScreen. You can order it straight to your house by going to jscreen.org. And you can ship a saliva spit kit to your house. You'll meet with a genetic counselor afterwards, someone like myself, who will explain your results to you, because that is really important. Making sure if you're doing genetic testing, you meet with a medical professional to explain why this is important to your health and how this may impact fertility in the future is huge. So that's definitely a great way to do it as well.
Okay, with the last few minutes that we have, let's shift back to fertility. Let's talk about babies. So, a well, before we get to babies, because I want to talk about that last stage of the egg freezing. We spoke about egg freezing, but we didn't talk about how does that egg that's frozen become a baby. So I
Yeah.
want to get there. I want to get there because I think that that's an important part of this whole discussion.
Yeah.
But I would like to ask, and this is a very common question: how much does this whole process cost? What types of what part of the process am I paying for? Is there any insurances that are covering this? Maybe speak about the medication, like the fees, the cost of the medication. Dr. Wertheimer, if you can give us a little bit of background about that.
Yeah. I hate talking
Usually,
about
like the
cost.
worst part of this conversation.
It is, and it's unfortunate that it's such a that it's so expensive. It again, it depends what state you're in, whether your insurance is mandated to cover it or not. If you have a great insurance like Progeny, if you work like one of the big corporate companies like Netflix or Google. But if it's cash, we're probably talking about somewhere between twelve to $16,000. It could be less. Sometimes, like we were running a crazy special this last year at HRC. If you missed it, I'm sorry, but stay tuned. If you we have a relationship with PUA, we give our PUA patients PUA referrals a discount. So there's certainly ways to get it a little bit cheaper. But yeah, you are talking probably around 12 to 16 or even 10 to 15. And that I think would include the medication cost. Medications can be anywhere between $3,000 to $7,000. They're very expensive. Sometimes if you've had a friend that's gone through the couple months before you and knows she's not using her medications, you may be able to get her to donate them to you, and that can save you some costs if they're not opened and they're not expired. Um, and then storage fees. So there will be storage fees every year on top of your cost. Most clinics, their packaging price will include their first year of storage or maybe even their second year of storage. And then after that, that's an important question to ask.
I
Okay.
also want to chime in, if it's okay, Dr. Wertheimer and Rabbi
Yeah,
Siegelman.
yeah.
With medications specifically, they are really expensive, and this is going to sound crazy. I've done this myself. There are price matches, so you can kind of shop around online and they can price match for you.
Sure.
So, just because one pharmacy has, I don't know, I'm going to use a medication like Gonalaf for 7,000, you may be able to find it somewhere else for 2,000. And there are huge price disparities. So take the time, if you have time to really shop around, get those medication different prices because you can get discounts. And also, and I can speak to this for myself as someone who was a patient, I never had fertility coverage, but if you did, like some things can be covered, right? Like there's certain things that can be. So it is
Mhm.
really expensive, but some stuff, right, Dr. Wertheimer, can be part of a GYN visit. Like not every single procedure is in the egg freezing big picture process is always fertility.
Yeah, true. In theory, if you have fertility diagnostic coverage, it should be covered whether you're doing with a specialist or your generalist. Sometimes insurances are dumb and may just cover it with a generalist because of the fact that they're a generalist. But for the most part, if you have a certain coverage, it should be covered with either provider. And in terms of costs of medications, shoot, what did I want to say?
Passenger
Oh,
care.
I just wanted to make a plug for HRC that we have a very good relationship with a pharmacy MDR, and so we give very discounted medications to our patients. So if you're in LA, we can help.
Okay, great. So with the remaining minutes that we have, so let's go back into the OR. The eggs were extracted, they were harvested. This is at that point, by the way, in terms of people were asking, at what point should you order PUA supervision, have a shomer or an observer there? For egg freezing, the observer, one of the services that PUA offers the community is to send a mashgicha, an observer, a shomeret into the lab to really witness and to observe the eggs leaving the body and then going into the lab, which is really behind closed doors, where the patients don't go, only the embryologists or even the doctors don't always go behind into the lab. It's really the world of embryology, and our mashgichot follow the eggs or the embryo in different other stages of IVF, and we'll make sure that when the embryologists are working on the eggs, they're maturing the eggs or fertilizing the eggs, whatever they're doing with the eggs or sperm, if the male is involved, we always have our eyes there. And when the genetic material is being locked up, it's being put away, it's being put in an incubator until the next day or two. So we have our special seal that we're able to tie it, which is tamper proof, and we'll know that that absolutely no one was able to interfere with the genetic material, in this context, the eggs. So the mashgicha would come in for the day of the retrieval, and then maybe the next day also when the doctors are finishing up whatever they need to do. And then at that point, we have our mature eggs. Let's say we told our patient that they successfully matured, I don't know, let's say 12 eggs. Okay, 12 eggs, 15 eggs, wonderful. It's an amazing number. So then I don't want to speak for Dr. Wertheimer, but just for the sake of time, those are put into a cane, and then they're put into liquid nitrogen and frozen. They're flash frozen in a process called vitrification, and they're frozen and they stay in that tank, and they can stay in that tank forever. Okay. Now, it's very possible, and maybe Dr. Wertheimer, you could speak to this, like how many of your patients actually come back to use those eggs, and how many will go on to get married and conceive children naturally, and then will call you and asking about discarding those embryos, those eggs, because they got married and they have 3, 4, 5 children of their own naturally. They're not interested in having any more children. But suppose you have a patient that gets married later and she's unable to conceive naturally. She comes back to back to HRC, whatever fertility center you go to. So maybe Dr. Wertheimer, tell us a little bit about what happens now. I froze my eggs 5 years ago. Now I'm 5 years older. Thank God I'm married, unable to have children. Let's go back to those eggs. Now what does it look like in terms of thawing them, and the success rates of the thaw, and any other kind of what does the medication look like? Am I going to be boosted with hormones again? Because just give us a little bit of background, and then hopefully we'll call it a night. We discussed.
Yeah, I'm glad you brought it back.
We discussed a lot tonight.
Yeah,
so there's a lot to talk about.
We did, and I'm so glad that you're bringing it back to this specific, because we would be very remiss if we ended this webinar and did not talk about what happens when you thaw the eggs. So eggs, as opposed to embryos, are one cell, and so they have a lot of water content. So when we freeze eggs, even with our most advanced method of freezing called vitrification, as Rabbi Siegelman explained so well, you still have about an 80 to 85 national thaw rate. So at HRC, we were actually a little bit above average last year, but even that was about 90%. So it is very conceivable that you can lose some eggs on the thaw. It's because of icicle formation in the cytoplasm of the cell. Embryos are much less likely to do that because they're multicellular, so they're in a sense hardier. They have about a 98% thaw rate. So some eggs can be lost on the thaw. Then you're going to fertilize them with sperm. In general, fertilization rates are about 70 to 80% of your eggs. From the ones that fertilize well to that make it all the way to that final embryo stage where we can then genetically biopsy them, about 50% will make it. And then from those that we biopsy, those that come back, a normal chromosomal number, 46XX or 46XY, depends on the female age at the time she froze her eggs, which is why we keep harping on doing this when you're younger. So if you're 34 years old, we expect the majority of your eggs are going to be normal. So if you're lucky enough to send off 4 embryos for biopsy, we're hoping 2 to 3 come back normal. If you're 40, we're hoping 1 comes back normal, just to give you an idea. Once you have a normal chromosomal embryo, that's when the magic of IVF happens. You have about a 70-75% chance of actually getting pregnant with a transfer of that embryo, which doesn't sound great because it's not 100, but I always tell people the bar in fertility is not 100%. The bar is 25 to 30%, because a highly fertile couple in their prime fertile years trying to get pregnant is only getting pregnant 25 to 30% of the time each month. Just goes to show what a nice, even natural, spontaneous conception is. Reproduction is highly inefficient, even in the best case scenario. So in IVF, we're giving you almost double the rate of natural conception, but it's not really magic. It's that we did this finding the needle in the haystack outside of your body and increased your efficiency.
And Rabbi Siegelman, if it's okay, I just wanted to chime in very quickly. Dr. Wertheimer mentioned a different type of genetic test we do on embryos. So there's a test called PGTA, which is something that looks for aneuploidy. So like a non-typical 46 chromosome number missing or extra. There's also a different test we talked about for PGTM. So that's for things like BRCA, or we mentioned Fragile X. So those are two different kinds of tests.
Right.
Most
Yeah.
people will do PGTA, correct me if I'm wrong, Dr. Wertheimer,
Right.
as a way to up their successful chances for having, a healthy baby and achieving a pregnancy with the embryo. PGTM, we don't just do for everyone. There's got to be a specific thing we're screening the embryo for. Not everyone does PGTM, if that makes sense.
Right. So PGTM would encompass things like looking for that BRCA mutation or Fragile X, or like if you and your partner carry a common disease like cystic fibrosis or something like that.
Yeah.
There was a question that was interesting. What are the side effects of the hormones? So I guess what should the patients be expecting while they're taking the injections, and also does it increase the risk of breast cancer?
Okay. No to breast cancer, not unless you have active breast cancer at the moment. And even then, we think it's very safe. But there's a lot of studies looking at the long-term safety of the hormones, and they are very safe. In terms of symptoms while you're actually doing it, most commonly moodiness, emotional. I tell people just be nice to everybody you work with, extra nice. And just a side effect of the whole thing is that you're growing your ovaries and they're taking up more space in your pelvis. And so you can be a little bit sore, and that's normal. And if you are somebody with a very robust reserve, you're really going to feel it towards the end, because your ovaries go from being the size of maybe, I don't know, a walnut, or, something like of that size, like 2 centimeters, to being, for in some people, the size of like an orange, or in some very, very, extreme cases, the size of like a grapefruit. So you're really taking a lot of room in the pelvis, and it's going to come with some swelling. And if I have a patient that has a very robust reserve, I kind of go through a special set of what to expect for them. So that's the most common. Sometimes people complain about the same things you'll hear about with pregnancy, like a little bit of nausea, a little bit of maybe breast tenderness, things like that. But I would say that's less common than the moodiness and just the overall like pelvic soreness.
And this is a really important question that someone asked. How many cycles are needed during each age? So I guess what's that? I'm not sure if you addressed this earlier, but I guess in one age bracket, one cycle could be sufficient. I know the answer may depend on how large you want your family, but typically, in order to get at least one or two or three, real healthy eggs, or four more, how many cycles do you think and you would need based on your age bracket?
It's so hard for me to give people how many eggs would you need based on your
Well,
egg bracket?
how
I can
many
age
eggs would,
bracket, I
I
can
mean,
tell you.
again, it depends on how many children you want, but I think what the question is alluding to, and the reason why it's so important to speak it out, is that it's important for people to know, with full disclosure and transparency, that when we say freezing your eggs, and we say especially the price and the cost, that's for one cycle. But for some
Right.
people, they may need multiple cycles in
Correct.
order to secure whatever responsible number, or whatever golden number they've discussed with their doctor. It may
Right.
require them to do multiple cycles. I think that that's a very important piece of information to make very clear.
Absolutely. So, yes, you may need more than one cycle. I would say the majority of women need more than one cycle. If you are younger, like late 20s, young 30s, you actually might be fine with one. There is a calculator there are multiple calculators that you can use online, egg freezing calculators. You just have to make sure you're using one that's based on validated data. There is one on MD Calc that I like, and you can literally put in your age, how many eggs you got, and you can see the percentage of live birth statistics for one baby, two babies, or three babies. And that might be a nice tool to just play around with to kind of help set expectations. So I'll take the most standard. If you're 35 and you have 20 eggs, you have about a 90 to 95% chance of one live birth coming out of those eggs. You have about a 60 to 70% chance of two live births coming out of those eggs. So some people might say to me, that's great. I hated this process. I'm never doing that again. I'm going to take my chances. And some people might say to me, no, I want to really ensure that I have like a 90+% chance of baby number two. And so I'm going to do this as many times as I need to get that amount of children. What I tell all my patients is that nothing is set in stone. Let's do one round. Let's see how you respond. Let's see how many eggs we get. And then let's go from there. If you're young and you still have a lot of years to meet, Prince Charming, come back to me in 6 months or a year. Let's recheck your AMH. Let's re-examine your social status and make another decision based on that and what you want. And the other thing I would say, as kind of like an insider's tip, your fertility doctors, your fertility clinic is interested in you coming back to do more cycles because that's how they make money. So if you know that you have a really low reserve, a really low AMH, it might be worth it to say to them, listen, I know I'm going to do this 2 or 3 times. Please give me a discount for coming back that many times and see what they say. It's not out of the question that they would lower it for you if they know they have a guarantee that you're coming back for a second or third cycle.
Okay,
And don't
we
tell
are
them
out
I
of
told you
time.
that.
We are out of time. It's already 9 o'clock. Time flies when you're talking about egg freezing, but I do want to ask both Bracha and Dr. Wertheimer to leave us with some parting words, some words of encouragement, some chizuk during this dark time. Uh, the egg freezing process can be overwhelming. The egg freezing process can be very scary. I know someone asked a question about the way they phrased it. Are people brave enough to give their injections to themselves? I don't know if you saw that question.
Yeah.
So the answer to that question is yes, there are some people, but many, many, many look to friends, neighbors, doctors, nurses to have injections. Actually, there's a service that Pua is working on now. We're about to launch it, where we have in different communities, Hancock Park and Pico in the Valley, we have people who will help you to do injections, to help you with your injections, to do the injections for you. And but I love the way that she phrased it. Are people brave enough? It's a scary thing. It can be overwhelming. And the fact that
Absolutely.
we are talking about it, and the fact that there are resources, and Pua is here for the community and here for you to see to it that you don't have to go through it alone, and you don't have to worry about this process, without anyone else holding your hand. It's not true. And the more I want to thank Bracha and Dr. Wertheimer for coming and to really sharing your knowledge about this important topic. It does a lot for our community. So I guess Bracha, you have any parting words for our listenership? And I love it that someone just asked when is part two. That's a great question.
I love that too.
I also
We'll
do.
be in touch.
I mean, I have two pieces. As someone who's gone through fertility processes myself, I would say like our community is amazing, and I can say what Pua and Rabbi Siegelman do is incredible. Use the resources you have in our community. They're really here for you in a non-judgmental way. They're just here to support you throughout the process. So I highly recommend you use that. I will also say like your providers, whether that's someone like me, a genetic counselor, or someone like Dr. Wertheimer, we are your cheerleaders. We want you to be successful. We want to help you. Make sure that you let us know what you need in that process. Be an advocate for yourself, which can feel really scary, but we can only help you if you let us know what you need. Egg freezing, when we had talked about Arby Siegelman and Dr. Wertheimer and I, can feel so scary for so many people, which is why we wanted to do this webinar. Just know that you have so many people in this community supporting you, and come let us help you. So come let to us and let us help support you in whatever way we can.
Thank you. And Bracha, if you could just email, if you're comfortable sharing your email with the in the chat, just click to share it to everyone.
I'm going to put share to everyone in the chat. My JScreen email, feel free to email me. And I'll also put the JScreen website. But I don't, does it let me respond?
Just right. If you click, it says two, just click everyone, and then everyone can see what you type.
I don't have that option on mine, but I can send it to you or by Siegelman and you can put it in.
Fine.
Yeah, you don't have that option.
Oh.
I would say that during these dark times, my interest personally is to help us to ensure Jewish continuity. And so this feels like it's my life's work. And I am I have the best job in the world. Rabbi Siegelman might have a close second. Um, And again, I totally like Pua is beyond amazing. I just saw one of the volunteers yesterday in the waiting room, waiting for the patient that she was there to accompany, and she was there reading Tehillim. And I just thought it's just so special that our Jewish patients have this added layer of tefillah and support, emotional support. And really, Rabbi Siegelman, you're doing such amazing things, and we're so lucky to have you. I prefer not to give my email unless you're a patient of mine, but you are more than welcome to reach me on Instagram. My handle is at Sahar Wertheimer MD, and I do Q&As every once in a while. It feels like a very triggering place on social media these days, given everything happening in Israel. So I've done less fertility education, but I'm always happy to get back to people in that capacity and to educate in that way. And I absolutely think we should do a part two, especially if people want to submit questions to Rabbi Siegelman, so we have a little bit more of a framework to work off of. I think we would all be happy to do that.
I definitely would as well. And Rabbi Siegelman and Pilat, thank you for just giving a place for people to learn this information in a way that feels comfortable and safe for them.
Baruch Hashem. I just see that there are 4 questions that came in, which is I'm not going to answer 4. Just it's the same question. What do you do with unused eggs, or what do you do with what is the halachic ramifications of unused frozen embryos? So I just want to put it out there before we end. There is a halacha that you should depart with someone with a dvar halacha. So the halacha is that an egg and an embryo is not life. An egg nor an embryo, even though it's the potential for life, it is not life. So generally speaking, we don't recommend people discard their eggs or their embryos, because once you discard them, you can't get them back. But in a situation where you definitely will not be using those embryos, for instance, they're embryos which are affected with a genetic disease, they're abnormal, they're genetically abnormal, you will never use them. So there is absolutely no question about discarding them, because again, life, according to halacha, according to Jewish law, begins with implantation in the uterus. Before that has happened, and we are just talking about an embryo in the lab, there is no violation of anything. It's not considered an abortion. It's not considered termination. It's not considered murder. It is not prohibited at all. As I always like to say, if on Shabbos, if the energy went out, if the electricity went out, you would not be able to get into a car and drive on Shabbos to turn the electricity back on to preserve the status of these embryos, right? If they're thawing, you can't go ahead and break Shabbos. Why? Because it's not pikuach nefesh. It's not saving a life. There's the potential for life, but it's not. So again, we always will have a very, very intense conversation with a couple who want to know, should they discard their embryos or not? Because again, once you discard them, you can't get them back. But assuming that you've made the decision, that's what the best decision for you as a couple and as a patient, and you're not interested in paying the fees anymore of storage. I always know when people call, so when is your storage date? January 6th. How did you know? Because that's the day that you always call. You always call when you get that bill that you have to pay for another year of storage. Anyway, so that's the halacha. Before it's implanted into the uterus, that's not considered life. I'm looking forward to seeing everyone back in part 2. People asked me about the recording, so I sent my email. Please email me for the recording, and we'll post it somewhere. Hopefully everyone will be able to see it. 1 second, let me just send Dr. Wertheimer's Instagram thing. Okay, and I want to thank everyone again. Thank the panelists and thank everyone who came to view this.
Thank you, Rabbi Siegelman. Thank you,
wishing bracha and hatzlacha to everyone. Have an amazing
Amen.
event.
Thank you so much.
All the best.